Thanks everybody for making the time this evening. We're all probably zoomed out to some degree, but hopefully this will be interesting and thought-provoking. So this evening I'm going to talk to you a little bit about implicit bias in medical education, and I have to thank Dr. Alan Cheng for suggesting this as a topic of discussion for Ground Rounds this evening. So before we go on, a couple of disclaimers and disclosures. I do receive textbook royalties from Springer, but they are unrelated to the content of this talk. This talk will focus largely on educators and teachers and the effect of our biases on our trainees. Training residents and students about bias is an entirely different hours-long talk, and of course they're both related. Stanford is probably ahead of a lot of other places in some of these issues, but every institution has room to improve, so I think it's still worth discussing. So a few goals. First, to motivate all of us, myself included, to improve how we recruit, evaluate, and train our medical students, residents, fellows, faculty, graduate students, postdocs, really everyone in the clinical and research realms with whom we interact. To improve our patient care and our outcomes by improving the diversity of our department, institution, and specialty, but also to help elevate all of our trainees so that they can succeed in their respective clinical and scientific careers. I'm hoping that the talk will make all of us feel a little bit uncomfortable about how we do things right now. I certainly did while putting the talk together. You know, many of you will have some of this information already, but having it all in one place was pretty eye-opening to me. So hopefully it will be for you as well. So right now I'm going to ask you guys to do a little audience participation, if that's okay. We're going to have a couple of these during the talk. If you can go to this website, www.menti.com on your device. I'm going to pull up and share a screen here with you, and I'd like you to type in the code at the top of the screen, 8517781, and you'll see a question on your screen, and the question says, please list 1 to 3 values that are central to your healthcare career, or if you're a researcher or scientist, then your healthcare or basic science biomedical research career. And I'd ask you to go ahead and enter those and put them up on the screen here. Give you guys a minute or two to do that, and we should start to see the responses popping up here shortly. All right, here we go. Whoever was that first person who broke the ice, thank you. All right. I'm going to give just another minute or two here as people's responses start to come in. So we can see that really a lot of these are values that we all share. You know, I think it would be hard for any of us to argue that any of the values that are up here are problematic, and we all strive for these things and strive to make these our drivers in our careers. So I'm going to skip to one more question here for a second, and ask you again, your Menti site should have switched to this new question. At any point in your education, medical or research training, or in your career, have you experienced mistreatment based on your identity? And that can be your gender, your race, your age, your ethnicity, your language, your geographic origin, where you went to school, anything. All right. So this is pretty telling, I think, that, you know, so far we have 13 people who have responded, and 100% of people who have responded have experienced some sort of mistreatment related to their identity. We have one person who said no. That's great. That means it is possible. All right, so this kind of gives you an idea of some of the basis for this talk. All right, so I'm going to go back to PowerPoint here. So we'll do a couple more of those Menti polls during this talk. So keep that window open on your browser or that website open. So just a quick outline. We'll have a general introduction about bias and the bases of it. And then we're going to talk about some specific issues related to medical and scientific education in the academy. And we'll alternate between discussions of the current state and then some mitigation or improvement ideas. So let's start by looking at active US physicians by gender. So in a recent survey, turns out women comprise about 51% of the overall US population, but just over a third of US physicians. So there's some difference there. When we look by race and ethnicity, underrepresented minorities comprise about 30% of the overall US population, but only 12% of active physicians. Now, when we hear the term underrepresented minorities, or URM, you'll see that throughout the talk. What does that mean? Well, the AAMC defines this as individuals who identify as African American or Black, Hispanic or Latino, Native American, Pacific Islander, or mainland Puerto Rican. All right, so again, 30-some% of the US population, only 12% of practicing physicians. How about faculty at US medical schools? So either physician or scientist faculty at US medical schools, less than 10% are underrepresented minorities. So even less represented there. What about LGBTQ physicians? So lesbian, gay, bisexual, transgender, and queer physicians and faculty at medical schools. Roughly 4% of physicians and students identify as LGBTQ. That is probably under detecting, but more and more medical schools are offering these options for people to specify their gender identity, so we should hopefully have better data over time. Interestingly, the AAMC actually now requires curricular content on LGBT healthcare in medical school curricula, as well as identification and compensation for an individual to act as a point person or resource for students who identify as LGBT. So there's some increasing awareness going on. But really, to zoom back again, how did healthcare and academic biomedical research diverge so far from the general population? Well, if we look at the last few years, in the last 2 years, 51% of medical school applicants and 52% of people who matriculated in medical schools in the US identified as women. And the percentage of women in both groups has increased steadily since 2010, so that's encouraging. In contrast, only about 14.6% of applicants identified as underrepresented minorities, and that has not increased over time. When we look at the next stage of training, let's look at residency. 44% of active residents identify as women, but that proportion is lower in the surgical specialties, and less than 10% identify as underrepresented minorities. So where are all these students going? Well, despite a steady increase in the proportion of women applying and matriculating in medical schools, the percentage of women residents has been rock stable since 2012. And for both women and minority physicians, there's a steady drop in representation from matriculation in medical school to residency to practice. For the scientists in the crowd, I apologize, we don't have similar data available for graduate school and postdoctoral fellowships, so I can't tell you whether the same pattern holds. And why is this happening? Well, part of this is probably because our identities affect our experience. There's this term called intersectionality, which many of you have probably heard over the last few months in sort of the cultural dialogues going on in this country. But what it boils down to is that each of us has a unique identity that's formed by the intersection of multiple different axes of identity. So those might be gender, race, ethnicity, language, geographic origin, income, education, etc. And all those things together make us have the unique identities that each of us has. And in turn, each of us experiences synergistic advantages or disadvantages based on that combination. And those can be social, economic, educational, professional, legal, whatever. But the fact is that all of us have this. And Audre Lorde, who's a well-known poet, feminist, activist, said there's no such thing as a single issue struggle because we do not live single issue lives. And that's really true, right? We all have identities that are very complex that affect how we experience our lives and what sort of favors or disparities or oppression we experience. Let's take a second look at the Stanford faculty, just as an example. This is data from fall 2019, so pretty recent. About 30% of our faculty across the university are women. When we look at racial and ethnic makeup, about 2% identify as Black or African American, 4% as Hispanic or Latina. American Indian and Alaska Natives were so few in number, they didn't even get a percentage from the university. And when we look at a further breakdown by gender and race and ethnicity, we can see that not only are there fewer female faculty, but there's an even tinier number of underrepresented minority female faculty, for example. So that's that intersectionality perhaps at work. So why does this happen? Well, there's lots of things that are probably contributing, but part of the problem is, frankly, we're all human. So our attitudes towards each other are directly affected by these intersections of identity. And so this is one graphical representation. So, our innermost identities are based on our unique circumstances and experience in life. The layer outside of that is the aspects of identity that we present to the world. Then there's a layer where we experience either favor or discrimination based on those aspects of identity that we present. And then finally, in aggregate, those experiences of discrimination or favor reinforce structures that raise or lower people's opportunities, which in turn then affects our innermost identity again. So it's circular. And why does this happen? Well, a big part of this is implicit bias. So implicit bias is a cognitive process, also known as unconscious bias, that is not intentional and it is not avoidable. So we all have it and it's not our fault. And it's based on the fact that humans process information by making classifications based on associations. That's how we interpret the world around us. And we form those associations based on what we see around us. So a large part of that, of course, is personal experience. If we have positive or negative interactions with certain individuals, then we will tend to associate aspects of that individual's identity or group identity with positive or negative characteristics. Cultural experience is a huge player. So what our culture teaches us, Hollywood, television, pop music, whatever else that we're into, tends to teach us that certain things are positive. And in the United States and in much of the world, it teaches us that being white and being male and being wealthy are the best things to be. And then, of course, our parents, our families, our teachers, our role models all model behaviors for us. They model interactions and perceptions and associations, and we imbibe those as well. And then we take this conglomerate of associations and we rapidly apply them to future experiences and future interactions and future individuals we encounter. And as physicians and scientists, we are particularly vulnerable because we have a strong belief in our personal objectivity. And it turns out, sadly, that the more you believe in your own objectivity, the more bias can affect your decision-making and assessment of situations and individuals. And for all of us, we work with incomplete information. We're often making high-stakes decisions. They're often under time pressures and often done under the influence of conflicting cognitive demands. And it turns out that not only does being apparently objective increase your level of bias, but having higher cognitive load also allows bias more room to affect our assessments of other individuals. Furthermore, ambiguity compounds that problem. When things are cut and dried and very clear, there's not a lot of room for bias because the decision is kind of made. But when there is ambiguity and uncertainty, bias really comes out to play. And this is true of all humans, including medical and scientific professionals. Our level of bias is identical to the general population. That has been shown in multiple studies. We are not special. And so the result is this trickles down the line. Residents in the United States, both men and women, for example, tend to unconsciously favor males for leadership roles or to associate male gender with leadership, and that's regardless of PGY year. Medical students similarly tend to associate positive attributes with white race and upper social class, as do nurses. So it's not just restricted to physicians. But interestingly, the effects of these biases on clinical decisions are less apparent in nurses and medical students than they are in practicing physicians. Why is that? A large part of that may be because we are trained and socialized in medicine such that these biases are reinforced. And we're going to get back to that later in the talk. And patients do feel these effects. So patients rate interactions with same race physicians, in other words, physicians of the same race as them, as more participatory. The same is true for gender concordance between the provider and the patient. Physicians are 23% more verbally dominant and 1/3 less patient-centered with Black versus white patients. And more than 50% of LGBT people report having at least one experience with some sort of healthcare discrimination. And you can imagine that treatment adherence is likely affected by all of these. Now, it's important to note this does not mean we should not and cannot see patients who differ from us. But it's important that we think about these effects and think about ways to counter them. These findings are likely the result of a complex combination of provider biases, patient biases, provider cultural competence, and a lot of other things. But in the end, the dilemma is that our patients seem to do better when they see physicians who are like them. On the other hand, our potential women and minority colleagues are progressively less well represented through the different stages of training and career advancement. And as Marian Wright Edelman, who's pictured here, said, you can't be what you can't see. So the problem feeds on itself. The less represented various groups are, the less likely they are to be represented. And medical school and residency training may be increasing the implicit biases of these future colleagues, which compounds these problems. So we're going to take a second and do another Menti survey. So if you can go back to menti.com, I'm going to open up a brief question here. All right, so the question says, and it has a new poll code there at the top, 1084057. So it says, please enter 1 to 3 words that describe your feelings about the material presented so far. And you can be totally honest about this. You can say you're excited, you can say you're offended, you can say you're depressed, you can say whatever you want, because this is all totally anonymous. All right, so really appreciate you all being so honest about this. This is wonderful. I see that some people are sad and embarrassed, frustrated. Other people say it resonates deeply. Some people say that they're tired of this. So speaking from their own experience, presumably. People say it resonates deeply. This is great. I really appreciate you all being so honest. All right, so I'm going to keep going, but keep thinking about this and keep thinking about how you feel about this and how you're processing this information as we go, okay? I'm going to head back to PowerPoint here. Sorry, you have to see the how the sausage is made here as I switch back and forth, but I couldn't figure out a better way. All right, so how is this all happening? We're going to try to break it down a little bit here, and we're going to talk about trainee selection, trainee experience, trainee assessment, and faculty hiring and career trajectory. And again, I beg forgiveness from our PhD and basic science colleagues that it's largely focused on the clinical side, but I think a lot of these concepts still apply. So thanks for sticking with us. Okay, so we're going to review a couple of terms here before we go on because they'll come up during the rest of the presentation. The first is stereotypes. These are all terms we've heard, I know. Stereotypes are judgments or characteristics that we attribute to specific groups of people or specific identities that may or may not actually be true. Implicit biases we've already talked about, and microaggressions are subtle, often unintentional verbal or nonverbal insults or degradations that are perceived by individuals that lead them to feel devalued, have reduced self-efficacy, and feel less worth because of a certain aspect of their identity. And then finally, stereotype threat. Stereotype threat is a really interesting phenomenon where when an individual perceives some risk of confirming a negative stereotype about their group, it actually affects their performance in the world. And so really interesting study, you can see some basic data from it shown here, where Black and white children were asked to complete a cognitive task. And in the right column, where it says no prime, this was when they just simply did the task. And the Black children did just as well, if not a little bit better than the white children. In the left column, we see what happens when the Black children were primed with a stereotype threat. So before they did the cognitive task, they were told that this particular task is more difficult for Black people. And guess what happened? They did worse. We're going to come back to this concept later in the talk, so please keep that in mind. All right, so let's start kind of getting into the detailed area. So let's talk about trainee selection. So implicit bias in trainee selection is one of the better studied areas of bias in medical education. And the basis is that, as we had discussed earlier, even at Stanford, a lot of our faculty tend to be white and male, and that's okay. Those individuals worked hard and they got to their place where they are right now. But we have seen that perhaps other groups are less represented than they ought to be. And so faculty tend to be more white and male, and faculty tend to be biased towards those groups. And biases across the general population favor those groups as well. And as we've talked about, physicians and scientists are no more immune to bias than anybody else in the population. And that includes admissions committee members who have been shown to have negative unconscious associations with Black and LGBTQ people. And similarly, to have more unconscious associations of women with family and home and men with career. And that plays out, for example, because women tend to be asked more often about their plans for marriage and children. Interviewees feel those effects, and some data suggest that they're more honest, for example, with gender concordant interviewers. And there's also strong data that our reviewing the photos of applicants before we meet with them compounds those biases. A lot of this research has been done by Dr. Quinn Capers, whose photo is up in the corner there. He's at Ohio State University. And I've heard him talk, and he's just brilliant in talking about this. And one of the issues that he brings up in his writing is that these effects are compounded with each layer of training or each stage of life. So imagine a child who grows up in a part of town that's disadvantaged because of systemic bias. That child is going to have fewer opportunities, for example, to go to a good high school, have a good guidance counselor, have a good college counselor, SAT prep. That in turn is going to affect their selection of colleges, which in turn will affect their access to resources that might optimize their chances for medical school, and so on and so forth. So we should be honest with ourselves and say there's a lot of this that we cannot control, but there are parts that we can, and that's what we're going to focus on today. So another example, the AAMC does not consider individuals who identify as LGBTQ to be an underrepresented group because of their sexual identity. And this is compounded by the fact that not all LGBTQ candidates are comfortable disclosing their gender identity at the same point in the application process. So we're probably not capturing them early on in such a way that we can recruit them or make the process welcoming to them as intentionally. Furthermore, there are some studies that suggest, for example, that LGBTQ applicants' partners and children are not included in the recruitment or application process in the same way as the families of sexual or gender majority applicants. So for example, we have a recruitment dinner for medical students or fellowship applicants or whatever. Oftentimes the spouses and children are invited to that, but LGBTQ applicants' spouses and children may not be as welcome or feel as welcome. But some gradual change is happening. So for example, as I mentioned earlier, some medical schools are now including gender identification options beyond male and female. There's some data that medical schools are starting to increase their LGBTQ-oriented curriculum elements as recommended by the AAMC, which may help with recruiting LGBTQ students. And just like any other group, a lot of medical students who identify as LGBTQ are interested in academic careers. So the same as any other interested student, we have to think about how we make those individuals feel welcome and facilitate their achieving their career goals. So how do we do this? Well, one simple way to improve is debiasing. Evidence suggests that being aware of your own biases is a critical first step, though it is not sufficient. It is necessary, but not sufficient. So as an example, Dr. Capers, who I mentioned earlier, had all 140 members of Ohio State University's medical admissions committee, both students and faculty, take implicit association tests to measure their race bias before they interviewed. 48% reported that they were conscious of their biases when interviewing applicants. 2/3 thought this testing was useful in reducing their bias, and 21% thought that awareness of bias affected their decisions and how they ranked applicants. And interestingly, after they did this experiment, they found record levels of diversity in their subsequent matriculating classes. So while we can't prove causation, that association is suggestive. How about residency selection? Well, it's very clear that gender has effects. From 2013 to 2019, one study demonstrated that when women ranked a non-surgical field as their first choice, they were equally likely to match in that field. But if they were trying to match to a surgical specialty, they were less likely to match compared to men. And this was despite men and women expressing similar levels of priority towards the intellectual appeal and clinical opportunities in their specialties. In other words, equal levels of interest. However, women were far more likely to report weighing previous experiences with discrimination and sexual harassment in making their specialty choice, which makes complete sense. But the result is that it leads to disparities in the applicant pool, because if people are not applying, we can't evaluate them for our specialty. And that cannot be balanced by our selection process alone. So again, there are things happening before we ever meet these individuals that may affect our ability to recruit them. But on top of that, our metrics may be part of the problem. So for example, Black applicants are more likely to be excluded for a residency interview at any cutoff point for USMLE Step 1 scores. So then you may think, well, does that just mean that Black applicants are doing worse in general in the USMLE? Well, maybe. But it turns out that self-identification as non-white independently predicts a lower chance of being invited for an interview, regardless of your Step 1 score. So that's a problem. Furthermore, standardized video interview scores do not correlate to any step of the USMLE. And I think we would all agree that the interview is really probably the central part of the candidate selection process. That's where we see them as a human being. And as we kind of get locked into video interactions through COVID-19 and other things, we have to think about whether the USMLE should really even be a part of this process anymore at all, I think. Some authors have suggested switching to a pass-fail approach towards the USMLE, but several surveys of residency program directors in multiple different specialties, both surgical and non-surgical, suggest that those program directors simply plan to shift their attention to other steps of the USMLE and ignore Step 1. So it doesn't really solve the problem. So what do we do? Well, one potential avenue for improvement is blinded interviews. Some of you may be aware that in the classical music world, this is a big thing. Blinded auditions were started by multiple major symphony orchestras when it came to light that minorities and women were severely underrepresented in those institutions. And so in this case, an auditioner, a musician, comes and performs behind a curtain, and the evaluators cannot see them. All they can do is hear the music. And it turned out that, yes, that transition was associated with increased representation of women and minorities in symphony orchestras that made the switch. So that's encouraging. How about in healthcare? Well, in one study, blinded interviews did not seem to affect rankings at all. However, in several other studies, it turns out that closed file interviews, in other words, meeting the applicant without reviewing their file, consistently produces different rankings than open file interviews. And those open file interviews would include either exposure to the full application or just to the Step 1 score. So on the one hand, it seems clear that reviewing the application before we meet the interviewee does bias us in some direction. On the other hand, closed file interviews can also introduce bias, because when we know a candidate beforehand, we tend to rate them higher in closed file interviews than unknown candidates. But that effect fades after subsequent file review. So once we have a chance to look at their files, then things balance out a little more. So it seems like both approaches, closed and open file, have strengths. So I would propose that a hybrid approach would be better. And so here's one option that I kind of came up with while thinking about this, is that one group of reviewers reviews the applications to select people to invite for an interview. And those reviews should happen without exposure to photos, names, or Step 1 scores, because we know from the literature that all of those things bias decision-making. And frankly, it's not clear to me at all that the Step 1 score has any meaning. Then a second group would do the interviews, perhaps by video, and then review the files of those interviewees to make their final rankings. And hopefully that way we can leverage the strength of both the closed and the open file interviews. Now, all of that's fine, but some authors, for instance, Dr. Poole at the Mayo Clinic, who's written a lot about bias in medical school admissions, has talked about looking beyond the phenotype, with the idea being that for a long time, there's been a big push for institutions to admit more minorities, to admit more women. But the result is that all of those people are just lumped into one group, URMs, or women, or whatever. And we just sort of paint them all with the same brush and say, great, we're succeeding. But really, it turns out that there's so much diversity within those groups that we're doing them a big disservice, and we're losing out on additional layers of diversity that could really strengthen the classes and the institutions and the programs. So maybe blinded auditions are no longer enough. Something to think about. All right, let's go on to the trainee experience. And this is going to be the pattern. I'm going to tell you about a problem. I'm going to suggest some solutions. Hopefully that works for everybody. So when we look at the trainee experience, well, it's hard out there. 54% of trainees across 51 different studies reported at least one experience with discrimination or harassment. And when we look at the little mini survey we did at the beginning of this, we had a much higher percentage of respondents, though not everybody in the group responded. And sort of depressingly, the most common source reported for mistreatment or discrimination or harassment was attendings, and patients and families were lower down. A recent example that many of you heard about this summer was the med bikini example, where a bunch of vascular surgery attendings sort of creepily stalked their trainees on social media and looked at their content posts and wrote about it. And essentially critiqued them for posting about normal life. That paper was recently retracted, and appropriately so, but it's an example of the sort of climate that exists. So let's look at medical students' experiences. Medical students, 68% of minority women report experiencing some sort of microaggression. 76% of white female students report the same, as do 51% of male students. Now you may stop and say, well, Karthik, you just talked about intersectionality. How come the minority women have a lower rate than the white female students? And the answer is most likely that they either didn't feel comfortable reporting it, or they just couldn't be bothered because it was so commonplace to them. So it doesn't necessarily mean that they experienced less of it. It just means they reported less of it. But regardless, microaggressions and similar mistreatment leads to these individuals feeling devalued, which has profound effects on their learning and their wellness. And it turns out that being female, being non-white, or being LGBT, or having that identity of any of those groups, are all associated with increased risk of experiencing mistreatment as a medical student, and at really high rates, like up to 40%, which is atrocious. How about minority residents specifically? Well, again, they tend to report frequent microaggressions, and in some studies, they have reported a feeling of a burden of having to act as ambassadors for their race or ethnicity group. And we all know that residency, and presumably graduate training in general, is pretty draining physically, mentally, and emotionally. So having that additional burden on your shoulders just makes it even harder to succeed or feel effective. And furthermore, many of these individuals report feeling like outsiders, which again makes negotiating training even harder. How about women's surgical residents? Let's get specific here, surgery residents. Women's surgical residents are 2/3 less likely to self-identify as a surgeon. They're 9 times more likely to perceive aggressive behaviors from faculty. And it's not just faculty. It turns out in several studies that nurses tend to be more hostile to women physicians and more deferential to male physicians. So it just reinforces that difference. Women surgical residents are also less likely to report mentorship relationships. And the result is that in certain studies, at least, they report that they're 2 times more likely to report difficulty completing tasks relevant to their residency. And we don't facilitate that as faculty. At least one study has shown that we offer women less operative autonomy after controlling for PGY year, gender of the faculty member, and the complexity of the case. Furthermore, women who experience more stereotype threat demonstrate lower operative skill scores. And that's despite the fact that in several studies, clinical competency committees and other groups evaluating their surgical skills rate these women's skills much higher than they rate themselves. So how do we get better? Well, one step is just structure and data. We'll talk a little bit later about operative skills and milestones, but frequent check-ins on operative skills and milestones are probably important here to make sure people are not only keeping up, but feel like they're keeping up. Structured rotations may help promote equal exposure to case diversity, different attendings, and provide increased autonomy. Structured mentoring programs are always helpful. And it's really important that we avoid treating residents as group ambassadors for their race group, for their gender, for their sexual orientation, or anything else, unless they volunteer to do so. Furthermore, there's pretty clear data that burnout in both faculty and residents increases the effects of bias. So periodic burnout assessments using short, easy instruments like the Mini-Z may be very helpful. How about attention to detail? Well, it should be obvious to all of us that we should have zero tolerance for overt harassment, right? If we see it, we got to say something. But beyond that, how do we deal with microaggressions? How do we make it so that trainees feel safe reporting to us when they have microaggression experiences? Well, a key step is to pay attention. And when we notice microaggressions, to take a stop and fix approach. So step one, assess the situation. If there's any issue with patient safety or clinical stability, or issue of safety of the trainee or staff members, then that's not the time to fix things. We deal with that first. But assuming that things are safe, first we have to recognize our own negative emotions. We don't like seeing our trainees mistreated. So we need to calm ourselves down and approach this calmly. The next step that authors recommend is to repeat the statement that included the microaggression and allow the speaker some time for reflection. Just repeat it right back to them. A lot of times people will stumble and realize what they said. And then we need to use objective statements whenever possible. So something like, Dr. X is a valued member of our clinical team or of our research team. To make it very clear that not only are they a team member, but they have credentials that earn them the right to be there. And then later you do a debrief. It's also useful to get back to our core values. So at the beginning of this talk, you guys entered some values that are important to you in your career. Essentially, that's a values affirmation, right? You stop and you think about what's important to you. And it turns out that that really helps. So one recent randomized trial that was done at Stanford was done on surgical residents. And actually, it included a lot of otolaryngology residents. So some of you may have been part of this. But the investigators asked residents to select 2 or 3 of the most important values from a menu of about 12 of them, and to briefly write down why they chose those. In the experimental and control groups, the ones who did the intervention and who didn't, there was no difference in male residents in how their surgical skills or surgical performance was scored. But in women, you can see in this graph here, that in the experimental group, their scores were significantly higher. And the idea was that this was thought to counter the effects of stereotype threat by reminding these surgeons why they were there. And other studies have shown similar effects for minority individuals. All right, so let's talk about how we evaluate our trainees now. When it comes to medical students, evaluations of women and minorities are far more likely to mention personal characteristics or personality characteristics, and less likely to mention competency-related items. Receiving honors in clinical clerkships is also strongly negatively associated with perception of stereotype threat. And it turns out that underrepresented minority students are 5 times more likely than other students to experience or perceive stereotype threat. So it's a self-fulfilling prophecy where these students are not shown that they can achieve honors, or they're not led to feel that they are expected to and capable of achieving honors. Then they have concerns about perpetuating that stereotype so that they don't achieve honors, which then just perpetuates the stereotype and it goes round and round. Furthermore, minority students, both underrepresented groups and other minority groups, are less likely than white students to receive better performance evaluation summary words, things like outstanding, excellent, or very good, even after their clerkship test scores have been adjusted for. Now let's look at resident evaluations. Multiple meta-analyses have shown significant gender bias in how we assess our residents. Women again receive more comments about their personality and their behavior, whereas men tend to receive more comments about their competency and agency, and we'll talk about agency shortly. Furthermore, evaluations of training milestones tend to diverge as training goes on. So women, on average, plateau in PGY2 year in some of these studies, whereas men continue to rise in their evaluation scores, such that by the end of certain residency programs, this is equivalent to a difference of 3 to 4 months of training. It's really significant. And this is regardless of the gender of the faculty member doing the evaluating or the concordance between the faculty member and the resident in terms of gender. Male surgical residents also tend to receive more positive comments with more standout words. It's not just attendings doing this either. Nurses tend to evaluate female residents as less able and having a worse work ethic than male residents. And I can tell you just from having been at Stanford for a few months, that's certainly not true in this residency program, but that's how it's perceived by nurses in various institutions. Furthermore, female residents and staff in at least one study were less likely to receive national awards. So even on the national society level, these biases exist. And when residents evaluate themselves, that comes into play too. So again, as I mentioned earlier, women surgical residents tend to consistently rate themselves lower in terms of their surgical clinical skills than do clinical competency committees. And remember, we said that as attendings and evaluators, we tend to rate women lower than men in these skills. So we rate them lower and they rate themselves even lower. How about letters of recommendation? Well, letters of recommendation tend to be shorter for women and minorities. They tend to focus more on effort and not achievement. They're more likely to mention personal information such as marital status, whether they have children, background, and so on. And they're more likely to use stereotyping words. So how do we do better? Well, I think on a large scale, sort of intellectually, we have to consider the effects of how we're socializing medical students early on in terms of gender stereotypes and how that might contribute to the sort of stereotype threat later. I think evaluation comments play a key role in this process because it shows students what we think of them. And one example of this, out of many possible, is directness in women trainees. So there's clear data, and I'm sure we've all seen it in our trainees or in ourselves perhaps, that when women are direct and speak up and are assertive, they're not encouraged for it, they're not praised for it. It's not associated with leadership characteristics. Instead, they're seen as rude or brusque or other negative things. So it's incumbent on us as teachers and educators to speak up when we hear that sort of comment. When we look at the global landscape of medical specialties, it turns out that specialties can be sort of graded in what are called in terms of agency. In other words, more active, more assertive, more procedural. Where we're actually doing something, or there's a perception of doing something. And those specialties tend to be surgical and procedural, including ours. And when we look at that, those specialties are typically associated with perceived greater levels of education, expertise, greater likelihood of achieving leadership positions, and greater reimbursement. Those specialties tend to have fewer women. So what do we do? Well, we need to choose our words carefully when we evaluate and write letters of recommendation. We need to emphasize accomplishments, not effort. We need to mention research and publications as objective signs of achievement. We need to use similar length for all applicants and use ringing endorsements rather than minimal confirmation. In other words, we want to say somebody's the best for the job, not just that they can do the job. We need to focus on their professional life, not their personal life, and use their formal title and surname rather than a first name. The University of Arizona has published a beautiful short guide for this, and here's some adjectives to avoid or include. You can see the ones to avoid are all personality related and effort related, whereas the ones to include are more achievement and leadership related. If you're ever not sure, there's actually an online gender bias calculator where you can just copy and paste the text of your letter or your evaluation and find out how biased it is. All right, finally, we're going to talk quickly about faculty career trajectory, because hopefully this is where everyone's headed. There's no real data from healthcare about faculty hiring and bias, but looking at the rest of the world and remembering that we're not any less biased than the rest of the world, it turns out that when racial minorities whiten their resumes, when they take away elements of their resume that make it clear what their racial identity is, they tend to get more interview requests. And this suggests that the system is making people feel forced to change their self-presentation or to cover up aspects of their identity that are probably important to them because it's part of who they are. Women, similarly, whose CVs mention motherhood status are less likely to receive job callbacks. And if you indicate on a CV that you are LGBT, you have a 30% less likelihood of receiving a job callback. Ethnicity and accent also affect hiring decisions, especially when somebody is of non-white ethnicity and has an accent. Again, suggesting that intersectionality effect. So here's looking at Stanford over the last 20 years or so. We can see in the top left that the number of female faculty has risen steadily, which is wonderful, but it's still a small proportion of the total. Let's look on the lower right and look at the green line towards the bottom of the graph. You can see when we look at underrepresented minority faculty, the proportion has grown very little, very, very little over 20 years. How about faculty success once they are recruited and hired? Well, one study of LGBTQ academic physicians suggested specific barriers to success, including poor recognition of scholarship related to that identity, lack of networking opportunities for individuals to meet others and collaborate with others who might share elements of that identity, and a hostile work and institutional climate. And one could imagine that this probably applies to women and minorities and any other group who already feels disadvantaged. How about faculty evaluation? Women faculty tend to receive lower ratings across all medical specialties, and the effect is more robust in specialties with lower proportions of women. And as I mentioned earlier, that includes those agentic specialties, surgical specialties like ours. Interestingly, the above effect is significantly reduced in programs with a gender-balanced faculty. So how about our department? Something to think about. How about promotion? Women academic surgeons are less likely to be promoted to full professor after controlling for key variables, including years in practice, first or senior author publications, NIH grants, clinical trials, and so on. And here's the distribution from Stanford recently. And you can see that from top to bottom, assistant to associate to professors, the red bar, which is the proportion of women, shrinks. Female faculty also describe lower self-efficacy in terms of their career advancement. They feel like there's less they can do to achieve career advancement, a lower sense of belonging, and lower congruence between their personal and institutional values. And that's despite male and female faculty having similar reported job engagement and similar aspirations to leadership positions. So it's not that women don't want to be in those leadership positions. So how do we do better? Well, let's start with hiring. Faculty recruitment faces the same concerns as recruitment of medical students, residents, fellows, graduate students, postdocs, or any other group. And so a standardized review process should be designed to minimize the effects of bias in those cases. It's important, right? Because women, racial and ethnic minorities, sexual minorities can all provide new insights and viewpoints that are just going to help the institution be better and better serve our patients in our community. As we talked about earlier, simple things like including candidates' families across the board can have a big effect. If an applicant has clearly identified themselves as part of or aligned with a specific group, then it has been shown to be useful to highlight resources relevant to that group. But we don't want to make assumptions and impute identity to anybody. We have to wait for them to self-declare. And similarly, it's really important that we don't share personal information about somebody's marital status, family, or background after they're hired, like for example, in an announcement, unless the individual has given permission to do so, because they may not be comfortable sharing those elements. In general, it is really important for us to form new associations. I was trying to find this movie, Black Women in Medicine. It's apparently a really superb documentary about multiple African-American women who are leaders in medicine and surgery. Really hard to find. I've not been able to track it down yet. I would love to watch it and share it. So if anyone knows how to get to it, let me know. But in general, forming new mental associations with positive attributes in these groups is useful. Furthermore, there was a recent randomized trial, really interestingly, looking at ways to improve success of women assistant professors. And so these faculty were enrolled in the Total Leadership Program to get leadership training. They developed local initiatives and task forces to focus on how to help them succeed. And then they had regular assessments and meetings with department and institutional leaders. And it turns out that the intervention group in this randomized trial showed not only improved academic productivity and career self-efficacy, but they actually worked fewer hours. So not only were they doing better, but they were doing it more efficiently. How about for underrepresented minority faculty? Well, there have been multiple studies looking at faculty development programs for these groups. And this nice summary from back in 2008 looked at what are the elements of successful faculty development programs. And they include things that make a lot of sense, right? Access to formal training in grant writing, networking, negotiation, and teaching, access to formal research training and collaborations, a salary stipend to protect research and leadership time, leadership training, targeted research awards, and then individualized faculty development plans that build on periodic values assessments and time-bound goals so people remember why they're doing what they're doing, and an awareness of the institutional promotion guidelines so their efforts can be targeted. These are all things that would benefit all of us as faculty members and trainees, but it's important to remember that there are certain groups that come in perhaps with some disadvantage, as we've shown through the data so far, and that needs to be compensated for. Stanford has a lot of resources just based on my Googling and web searches. Some of you in the audience may have interacted with some of these groups. There are a lot of resources out there to help people with different identities. One thing to highlight is the announcement by Dr. Jackler recently about a departmental funding opportunity focused on minority and LGBTQ populations. So please submit proposals for that. And then just today, actually, just before this session, Dr. Maldonado sent out an email announcing that Dr. Terrence Mays has been appointed Associate Dean for Equity and Strategic Initiatives and Executive Director of the Stanford Medicine Commission on Justice and Equity. So the institution's trying, but we can certainly do better. All right, we're gonna do one last Menti quiz. So I'm gonna switch you over to that. And then we'll wrap up. Thank you for hanging with me so far. All right, so again, there's a new Menti poll with a new code 8486667. I'd love to hear from you again now that you've heard the rest of the talk and maybe some potential solutions or approaches to these problems, how you're feeling about things. And I would invite the residents and the faculty and the staff and anybody else who's listening to throw out your ideas here. I'll give it just a minute. Wow, look at this. This is great. Thank you guys for sharing these. I mean, we have some people who are encouraged and hopeful and determined. Others are frustrated and exasperated and hopeless. And that really, I think, reflects the reality of how a lot of us feel, right? I mean, this year and Black Lives Matter and a lot of other social movements that have come to the fore have really brought a lot of these feelings. And I'm sure we all feel elements of all of these. But hopefully that leaves at least a little bit of hopefulness or determination in addition to the discouragement. All right, I'm gonna skip to the next question if that's okay, just because I don't want to keep you guys late. But thank you for sharing those feelings. All right, so this one's a free text answer. Should hopefully pop up on your device. I'd like you to name one lesson, just very briefly, that you'll take away from this, or one thing you might do differently in the future. Because I would love to learn from all of you, how you've processed this, and hopefully we can all learn from each other. So give that about 2 minutes. Yes, whoever put that first one in, there is room for people like you. That's our job as faculty, is to make room for people like you. Yes, speak up more, advocate for myself, collaborate. Oh, thank you. Whoever said that, let me know. Think differently about my evaluations, improve recommendation letters, be more assertive regardless of how I'm perceived. Good job, that's great. Be a mentor in a way that I did not experience personally. Excellent. Yes, you do not have to be of the same race or gender or anything else to be a mentor. Vote Trump out. Oh, I won't say anything, but y'all know how I feel about that one. Strive to reach further and higher. Yes, so you can inspire others. This is great. Adjust applicant interviews. Wow, this is awesome. So, you know, I love that you're all sharing these, and be more mindful, be aware of my implicit bias, especially toward women. Knowing that I have implicit biases and stepping back. Learn about others' experiences. I mean, this is incredible, guys. Thank you. All right. I'm gonna go back to the PowerPoint for a second, but I hope you've had a chance to look at these. And I mean, I'm super inspired by all of you and what you've said here. All right, let's go back to this for a second. And I'm just gonna go to this last slide and just thank you all for your attention and your time, despite being brain dead from all the Zooms we have every day. Thank you for participating. I welcome any questions, comments, criticisms, conversation, whatever. If you want to collaborate, let me know anytime. My email's right there. And if you noticed any of my biases, throw them out. I would love to know about them too. Yes,
thank you, Perfect. It was wonderful.
I appreciate that. Thank you, guys. Please post comments on the chat or questions, or if you want to speak up and say them, that's great too.
Yeah, I would encourage this to be, you know, a frequent discussion among faculty and trainees. This is something we could, you know, frequently think about.
I agree. This is such an important topic and very timely, of course. Uh, I am certainly open to making some adjustments to the interviewing process this year. Just listening to the talk, maybe setting up one blind interview room of some sort. We used to do multiple mini interview sessions to try to get rid of some of these biases. I don't know. I mean, we're looking at the data now, and I don't know if it's going to show anything in terms of removing biases in terms of race and gender and things like that. But it'll be curious when we get all the data together to see if that happens.
Good thoughts.
You've all got my contact info. You know where I live and what I do. So come find me if you want to talk more about it. If you have your own experience you'd like to share, I would love to hear them, or wisdom about how we can do better. And for the trainees especially, I'm happy to try to be a filter. If you want to come talk to me, I know Dr. Sung and a lot of the other faculty are excellent resources as well, but please count me in that group as well as somebody you can talk with. All right. With that, I wish you good night.